Good afternoon, everyone. This is Tina Schween with Flawless Health, and I'm joined today with Jennifer Palagi from Idaho. First and foremost, welcome to today's call. Secondly, we apologize for any confusion in regards to logistics. We had a glitch in our process in regards to phone numbers today. We will do a root cause analysis on that, but my apologies for any confusion it's caused. We will be recording today's call for those who unfortunately were not able to connect, and we will be distributing that information. As with all of our calls and webinars, we will be muting all lines until the end when we open for discussion. We do have a chat box in the lower right-hand corner of your screen. If you are sure to send to all participants to use that selection in your drop-down menu, you can type in comments, questions, hit send, and we can kind of scroll through those throughout and address things we need to, or hold those until the end and address those questions. Today's call is the fourth of our four-part series. We've covered four topics. In total, we will have covered four topics. The first being avoiding insertion when possible, so very much a focus on appropriate indications. The second piece, the second topic, was inserting care. The third, proper maintenance. And today's call will focus on prompt removal. As with our previous calls, the agenda was the same. We'll kick it off with a patient story. We'll briefly touch on the best practices we've all read about. And then we'll feature real-life stories from hospitals both in Washington and Idaho on how they're approaching today's topic, prompt removal. We'll then move on into discussion and then into next steps. So we'll go ahead and move to our patient story. Again, it's a marker to help us remember what this is all about. It's about preventing harm and increasing patient safety. And our case today is about an 85-year-old female. Karen Pittman, would you like to walk through the case study, or would you like me to? Go ahead. Okay, great. So in this example of a CAUTI that occurred recently, there was an 85-year-old female who was admitted to a hospital with small bowel obstruction and an incarcerated incisional hernia. At this point, at the point of admission, no Foley in place. The following day, a Foley is placed for strict I&O, and the following day after that, so the 24th on this timeline, this woman undergoes an exploratory laparotomy to repair the hernia, and she has a thoracic epidural in place for post-operative pain. On the 27th, so day 5, she develops a fever, 101.9. There's a UA culture ordered, and it returns enterococcus faecalis. A dipstick is done that shows TNTC white blood cell count, and she started on fetal moxicillin. On the 2nd of March, she develops an epidural hematoma and has a procedure for the epidural to be removed and the hematoma to be evacuated. She's discharged on the 8th to skilled nursing facility with the Foley due to limited use of lower extremities. So, big picture on the Foley in blue there, no Foley upon being admitted, Foley placed the next day, left with Foley. Along the way, developing a catheter-associated UTI. There was some catheter-associated UTI follow-up in terms of looking at this case. And what that revealed was that there was documentation for aseptic Foley insertion. A closed system was kept intact. They, in fact, did have documentation of using a stabilization device. Most days, there was a sticker completed on the chart indicating that the physician said that Foley was still indicated, reasons being strict I&O or reason being until epidural removed. They did note that there was inadequate documentation of Foley care along the way. So I think this case is just an interesting case, one again, because it points out we're talking about real people and how the placement of the Foley can change care and can change lives. In terms of the follow-up care follow-up RCAs here. Certainly maintenance of tissue, but I think one could also question or discuss whether that fully was indicated in the first place. Was strict INL needed? Was it not? And could that fully have come out more quickly? We're going to move on now, just talking about some of the highlights on best practices. I'm going to turn it over to Jennifer to speak to guiding principles.
Hi guys, this is Jennifer Pelagi at Qualis Health in Idaho, and so we're just going to spend a couple of slides rooting ourselves in the key concepts, the key recommendations around removing catheters appropriately and as soon as possible. We know that we're talking to people who already understand these concepts, so we're just going to touch on them. The guiding principle, of course, is that the duration of catheterization is the most important risk factor for development of infection, and that comes out of the SHEA and the Infectious Disease Society of America Compendium. And so really, when you think about it, it's very simple. If we ensure that the use of an indwelling catheter is necessary, and we actually assume and follow up and make sure it's necessary through indications, then the most important strategy is to get the catheter out as soon as possible. Once in, get it out. So the two biggest action items around that would be to review the necessity for the catheter daily and then remove promptly. On the next slide, Tina, are the 4 or 5 main bullet points around hardwiring that daily review and removal. Those number 1 and number 2 is reviewing the necessity and remove promptly. How do we do that? Well, we have to remove remembering as a factor. It can't be about the infection preventionist remembering or having time to go up to the floor, although that can be a part of our processes. It can't be about the physician remembering that they have a patient with a catheter. We have to remove memory as a part of the process, and we have to hardwire systems that make it happen in a fail-safe way. So when we're thinking about that, we have to build in these things, one or more of these things, multiple things, to make sure that happens without somebody having to remember it. We want to confirm the necessity in the daily nursing assessment with every shift if possible, if that catheter is needed, and comparing that against indications. Secondly, another big movement is to implement nursing protocols that allow for removal of the catheter by nursing staff based on a protocol that's approved around the recommended time frames and around appropriate indications to remove that. There's also implementing automatic stop orders for within 48 hours after insertion unless there is a renewal order present. Another item, and these come out of the Institute for Healthcare Improvement How-To Guide, and of course there's several bodies of great that have great recommendations, and they all end up falling into these buckets. But the patient record needs to have reminders requiring physicians to document the indication for continuation of the catheter, whether you're using a paper medical record or an EHR, having those triggers to require them to document indication or to remove it. We added a 5th one here, because it wasn't exactly spelled out in the IHI How-To Guide, but it makes a lot of sense, and we're seeing it with a lot of providers, and that's to assess necessity during daily multidisciplinary rounds, so having that multidisciplinary round component to your hardwiring processes. So the next thing we're going to do is engage you a little bit. Now that we've finally got everybody on the phone, we want to ask you a polling question and see what all everybody is using. So the question is going to be, and after we get going, you'll have 45 seconds. Oh, the time has started. What triggers do you use at your facility to prompt removal of urinary catheters? And you can check box any and all of these. If you assess needs daily with multidisciplinary rounds, with nursing rounds, with the patient and family, if you use nursing protocols, just click any of these that apply to your facility. Alerts, stickers, things like that. Go ahead and click them all. You still have a good 15 seconds to click the ones that apply to your facility. And if you have another one that's not even mentioned, like something that's brilliant and hasn't been listed here, put other, and then we'll quiz you about it later. All right, so our time is up. And in just a moment, our WebEx person will post the results for all of us to see. There we go. And you can see the layout. Feel free to go down and you can click in your own polling box and move things around so you can see it better. So using multidisciplinary rounds, 34% daily. Wow, and half of the people are using nursing rounds and shift change as that cue for assessing need. And about a third of the people weren't quite ready to give an answer, and that's all right. There's some paper chart stickers and automatic stop orders in almost a quarter of the people who answered. So really interesting results and across the board some different interventions being used. So let's go ahead and move on from our poll, and let's hear from, we had 5 facilities across Idaho and Washington that are going to talk to everyone today. They're just going to take about 5 minutes each, maybe a little more, to give you the best of what they do that helps them succeed in removing catheters on a reliable basis in their facility. We were going to start with Jennifer West of Northern Idaho Advanced Care Hospital, which is an LTAC, long-term acute care facility in Northern Idaho. She unexpectedly was not able to be with us this afternoon due to a variety of things. You know what can happen in the hospital environment. But I do have some of the notes. I got to visit her facility and talk with her and her CEO, and I got to huddle with her this week on some of the things that work well for them. And being such a high acuity center where lines are everywhere, and they're going to be everywhere for a while, it can be particularly challenging. But they are tackling these issues just like the acute care facilities. And it is important. It's on their radar for 2012. I've talked to a couple of LTACs. They're tackling these issues just like the acute care facilities, and they are having to report into NHSN later this year. So when I talked to Jennifer at Northern Idaho Advanced Care Hospital, that's one of 3 LTACs in Idaho, she listed a few key supports to removing catheters in her facility. And where they haven't driven it really, really well into the daily multidisciplinary team, because it's a little bit of a different environment, they do have a very effective weekly rounding, and it's staggered throughout the week. So they have weekly rounding on every patient that they have, staggered throughout the week, and it's interdisciplinary case conferences where the full interdisciplinary team attends, including case management, dietary, the infection preventionists, the practitioners, everybody's there, and they're addressing everything. We talk about all care and all lines, and the catheters are addressed. They do have sort of a trickle down to the daily care. The nursing staff coordinate really closely with the lead nurses on the units to then implement and to continue evaluating on a daily basis. The thing that I found incredibly unique about this facility that I didn't hear at others is that they engage the family in the case conferences. And so they invite them, the case manager always invites the family to those case conferences where they're talking about clinical care and changes in clinical care. So in an age of wanting to engage patients and family more, I thought that was unique, and having the patient's family right in the room with you to hear the things that are taking place and things that are being evaluated. They have also built a really strong team culture where both the clinicians and the RN frontline staff are equally vested in stopping the lines and have taken some ownership over that. And they are part of the healthcare system. They're not just a lone facility. And the healthcare system is tackling the issue where some of their sister facilities had implemented automatic stop orders. So we're hoping to get an example of that, be able to pass it on to you. And they're looking at doing that, especially whenever they get onto an EHR. So what we'll do now is I'll go ahead and move on and hand this over to Jenna Maggard in just a second. I'll mute my line and she can talk to you for 5 minutes or more about some special things they're doing at their facility. Jenna is the infection preventionist and employee health specialist at West Valley Medical Center in Idaho, and they are part of the HCA healthcare system. And so, Jenna, if you don't mind, I'm talking about some of your key supports and things you feel like our best practices in your environment, that would be great.
Thanks, Jennifer. I don't know if we do anything that's really any more special than all the things that I just heard. But we try to take a team approach at all the lines that are in. Our policies say that we're going to assess our urinary catheter Foley's in 48 hours for removal. We do have a Meditech reminder. We used to use a sticker on the chart, but we do have a Meditech reminder now that pops up and reminds our nurses that the Foley has been in for 48 hours. We check, when I come in the morning, I pick up a midnight Foley sheet from our house supervisor. It would be really nice if we could just pull a report off and say that these are the exact Foleys that are in the facility. But as far as documentation is not perfect in our electronic record yet, I'm still, because of our national reporting, I'm relying on a hand count for a midnight Foley sheet. So when I pick that up and run my report, I know the Foleys that are in. We have an interdisciplinary meeting at 10 o'clock in the morning, and I go over all the Foleys with the clinical supervisors on the floors at that time. It's to the point now where they say, yes, Jenna, this one has to stay in. We do have the order on the chart, and this is the reason. So there's also the core measure nurse that is making rounds, and she's making rounds on the skip thing. So there's another reminder there. And it gives our supervisors, I think every time we have a reminder, we look at things closer. I appreciate these phone calls because from the second phone call, I got an interesting idea for the hooks on our IV poles, and we are pursuing that because as we've done point prevalence studies on our Foleys and looked at the lines and if they're below the bed and if they're close, system, and just making sure that we're having the secured, that the stat lock is on and all those things. We did find that as people were ambulating with an IV pole, that maybe we didn't have the most beneficial way of having that Foley bag secured there or hooked there somewhere, so it's actually below the bladder, not going to get stepped on and things like that. So we are pursuing those hooks. Like I said, I don't think that we have anything that's exceptionally special. We do have a very good team environment. We do look at those Foleys and assess for the need daily and as an interdisciplinary team, and we have had some good results from that. So, Jennifer, I don't really have anything else.
Thanks, Jenna. And we'll move on to talking to the three other places in Washington. I would just, and I forgot to ask the other day when we were talking about this, but if you've had any HCA initiatives that come, wafting over your hospital, or if they have a particular focus in this area too.
Well, we are not. We had to start reporting into NHSN sooner for HCA than the first of this year. We actually started last year. We always have initiatives, but right now our big initiative is in our Stop SSI program, and so. Like I said, we always have initiatives, but the CAUTI isn't the top of the list one right now.
Thanks, Jenna. Tina, I'll turn it over to you and your crew from Washington.
Thanks so much, and thanks for those two really great stories. It's just wonderful to hear about daily process, things that are just part of the flow of the day and addressing Lyme. We are going to travel now over to Washington. We're going to cross on over. We've got three different folks who are going to share what they're doing at their hospital. Karen Pittman from Capital Medical Center, Connie Coyne from Kennewick General Hospital and Cheryl Berger is from Deaconess Medical Center. Let's kick it off in Washington with Karen. Give us, again, a 5-minute or so highlights on how you're approaching prompt removal at Capital Medical Center.
Well, thank you. I thought I would start by kind of taking you down memory lane of how we got to where we are at. It hasn't been a real smooth process, but I will start from the beginning. We started trying to initiate nursing protocols back in January of 11 and took it to some different medical committee meetings, and it soon was found that we're not going to be able to go that way. So we went to Plan B, which was to initiate the stickers, and with all of the reasons that the doctors found were appropriate. So in about October, we finally got the stickers on the charts, and that was after a lot of education and letters to the doctors and educating to the nurses. And then we started very slowly seeing compliance with those stickers being put on and filled out. And then we got all the questions of how do we find the date for when the catheter was inserted, which was a whole other process. So I think we finally have that figured out, and we are doing well with the stickers being appropriately placed and being filled out by the physicians. So we do that at the next day. So even if they had a Foley put in at 10 o'clock, by the next morning they have a sticker on. We thought about going to the second day to go along with the skip criteria, but because doctors don't necessarily round at the times that would fit well with that, we decided to go with just the next day period, and so that's what we've been doing. We also have started bedside nursing reports, and the nurses are supposed to ask each other whether the Foley catheter is necessary and whether it can come out, and do they need to be asking the doctor about that. So that is basically how we've been doing it, and I wish I had one of those other ideas that I could share, but that's pretty much it.
Thanks so much, Karen. I have a feeling there may be some questions after we hear from other folks about how you figured out the date and getting that where folks could find it more readily. But first, let's go on over to Connie Coyne in Kennewick. Connie, let us know how you're approaching promptly removing Foley catheters at your institution.
Can you hear me?
We sure can.
Okay. What we did is I went to the nurses in ICU because they like change and they like to be creative. And so the nurses in ICU have whiteboards in every room with their name and who's their nurse and all of that. And so what they did was they came up with this idea themselves that they keep track of their central line days on the whiteboard, and so that just kind of morphed into with the Foley catheters, and so then I make Foley rounds, I call them Foley rounds, but I go to every unit that I can and try and do it every day and look at the card X's, and the nurses know what I'm looking for, and so when I see somebody and I stop and I ask them, and then the next day when I go, that Foley is out. But the ICU does really good about keeping track and getting those catheters out themselves. So that was something that they came up with their own self. And then their director is quite supportive. I find that if your directors are real supportive, then your staff gets involved and gets excited about doing these things. And incidentally, as I was preparing for this, we had looked at the German devices last year, and I can remember the product that we are using. And when I started making phone calls this morning to figure out what the product was, I found out that we have had a communication glitch, and only 2 of the units are using them, and the others are not because they didn't know anything about them. So there's going to be some more teaching done. So that's our story.
Thanks so much, Connie. It is interesting how it's a journey forward, and it's actually wonderful when finding those gaps and being able to identify them and rectifying them. I'm fascinated with the whiteboard use. I think it's pretty awesome that you went straight to the ICU nurses to ask them for their ideas, and that they already had a process they could adapt, and are perhaps thinking about Foley catheters or indwelling urinary catheters from that line perspective. It's an additional line in. It means it's a potential source for infection. I think it's fabulous. We're going to turn now to Cheryl Bergerud at Deaconess Medical Center. Let us know what's going on at Deaconess in regards to prompt removal.
I have to add that Skip has probably done the most for me in terms of getting Foley's out promptly. So despite what I'm going to focus on, which is our nurse-driven protocol, that has been a huge emphasis here. And one of the things that has been done, we need to do some more hardwiring for our staff on the whole Skip Foley removal by second-day post-op piece, because it's reliant on our core measures coordinator to send out twice daily emails to the directors of the units about which Skip patients, and they do it for all core measures, but I focus on the Skip one, what day that Foley is due out to meet the requirement. And because of the high priority that's taken in our organization, we have had very few Foley catheter failures in the Skip measures in the last 2 quarters now. So the efforts are very great, but the results have been very good. And I know, in tracking UTIs, I've seen some improvements even in the first quarter. So I think Skip has been a big thing. But we were also able to get a nurse-driven protocol passed through our Med-Exec committee. I used all of the standardized bundled criteria for urinary catheter criteria within that nurse-driven protocol, but I had to negotiate with the anesthesiologist to add epidurals, because they were very concerned about urinary retention for the patients that have epidurals in for pain management. So we negotiated and we went ahead and added that to our criteria. One of my infectious disease physician, who is the chair of my infection control committee, was with me during all of these presentations and to the medical staff, and so of course I gained quite a bit of credibility with that. But the discussion around it to the physicians, there wasn't a whole lot of pushback from our physicians at that point, which was beyond a lot of discussions around the Skip measure itself. So they've already been hearing about Foley catheters quite a bit, but I was surprised at the controversial nature that this actually took. There really wasn't a whole lot of controversy in the discussion, so they approved it. I did predictably tell them, and have found it to be true, that my biggest issue is not necessarily that the nurse is going to pull these catheters, without a whole lot of thought to it, and that the nurses at my facility are probably like nurses in a lot of places. They really like their Foley catheters, and they're less likely to pull catheters that should have stayed in than they are to leave them alone. So notwithstanding the scope, the Skip piece has pushed a lot of it in the surgical patients, but in the non-surgical patient population, we're still having some struggles to hardwire that with the nursing staff. So one of the things I trialed was the Foley catheter checklist, so that they would have a daily checklist of reasons for the Foley catheters, and that really did not work well, because I found that the director was filling them out on the unit that I was piloting, not so much the nursing staff. So that was pulled for that reason. So doing more rounding on those and finding out, who still has catheters in for longer periods of time and why are they in. We use the BARD kits, and just speaking to some of the resources that they brought to us, they did a point prevalence study for us house-wide on the number of catheters that were in, and found that the nursing staff had difficulty articulating the reasons that the catheters were in and whether that was an adequate reason for those to be left in. So there's continuing education that needs to happen here with our staff on what those indicators for Foley catheters are and are not. And this is my second year of detailing those in skills review with the nursing staff, and we need to do some further work on that. So the kits do provide the stickers with the indications on it. They provide a sticker for the drainage bag and a sticker for the chart. So there's quite a bit of really good
tools within that kit, as well as having the securement device in the kit for the Foley catheter. So another interesting point that we found in the point prevalence study that they did, they actually commented on in our whole house on the day that they did. We run 180 to 200 patients in the hospital, and on the day they came, we only had 45 patients at that moment with Foley catheters that we were looking at, and they said, a year ago this might have been about 100 instead of just 45. So they had comments about the progress that has been made in reducing the frequency of patients having catheters, just in general. But an interesting note, when they did that, when one of the criteria was looking to see, were they below the level of the bladder, were they secured, was the tamper-resistant tape still in place on the catheter so it was a closed system, that kind of thing, and was it touching the floor or off the floor? And one of the interesting points that I've had to make with the nursing staff is some creative ways to keep that Foley bag off the floor because of our emphasis on reducing falls in our patients. The beds go so low that the hook meant to hang the Foley bag on the bed is now too low, and routinely would hit the floor. So that is a whole other unintended consequence of another initiative that is being undertaken to keep patients from falling and injuring themselves. So more creativity is needed there. But other than that, I was again surprised that the nurse-driven protocol was so easily passed with our physician staff. It's pretty simple, and my next step at this point is just to really get some more nursing education on board so that they understand what those criteria are and that they know that they can take those catheters out. That's kind of where we're at.
Thanks so much, Cheryl. That's exciting. Exciting to know that you're in a position where your nurses are empowered, and then taking that next step to let them know that they are empowered and to act on that. Our next slide was really to sort of open up that discussion about nurse-driven protocols. I'm curious, just to sort of kick the conversation off a little, for you, Cheryl, how long has it been since that nurse-driven protocol was passed through?
September of last year, so it's just about 6 months.
Great. And in regards to Karen, you mentioned that was sort of where you started, with looking at nurse-driven protocols, and that was not something that was able to move forward. Did you comment at all on what the barrier was there?
It was mostly just a couple of surgeons who just felt like they did not want to give up control. And, we talked about, we're not like was said before, we're not going to err on the side of taking out ones that don't need to be taken out. We're probably going to err on the side of leaving them in. And we would have to be calling them, and how this would maybe help not having to call them at 2 a.m. But no, they just did not want to give up control.
Got it. I think that is certainly what I have heard at other institutions as well, that is just not something that certain services are ready in terms of those physicians and those services. Connie, what was your experience in terms of discussions regarding nurse-driven protocols at Kennewick General?
Well, we haven't really started on the nurse-driven protocols yet. We've got that policy in place about these are the people you use the catheters on and you get it out as soon as possible. And that policy's been in place for a while. But we discovered last fall that we needed to do some re-education. So in skills care in March, we hit it hard, and I hit the ER nurses hard about not putting them in. And then we've got, the SCIP protocols we're doing really well with those. So what I'm going to do is take some sample nurse-driven protocols, and we'll talk to my hospitalists, and because they take care of the majority of the non-surgical patients in the hospital, and see what they think, and then start there.
Wonderful.
Yeah, if you forward the slide, we can show them an example of just such a protocol.
Oh, that would be great.
Yeah, this is an example of, this is Jennifer, and this is an example of one. especially since we started focusing on CAUTI in this QIO scope of work that we're in right now, Tina and I started digging to see, what's out there. It's still, nursing protocols. Some people have been doing it for a few years, but for most other hospitals, this is kind of, new and different and cutting edge and a great way to hardwire getting them out and reduce as many steps as possible at doing that. So this came from Miriam Hospital in Rhode Island, and this was just one of several that we found off of the APIC, Association for Professionals in Infection Control and Epidemiology, their listserv, and the way that they share materials between different people who are part of that organization. And also, I think we pulled some other ones off of the SCIP listserv when it used to exist. So this is just one example of how, and this is just the first few paragraphs, but it does show, the purpose is to get the catheter out, and here's the exclusion criteria, the people who we wouldn't apply this protocol to. So that right there, right up front says, we're not going to apply this to these folks. We're going to still go through our old processes of, checking on them, still checking for indications, but going back, for orders. So the bulk of the patients, the bulk of the time is where this kind of protocol will take place. Very excited to hear that Cheryl's having some success. I know in Idaho, as I talked to, all my friends and providers across the state, I haven't heard of anyone, and they can throw up their hand right now and say so when we go to a discussion point in a minute. I haven't heard of anybody implementing one in Idaho. I would love to see that happen, or see somebody do it. A PDSA cycle or try to put one together, but it's not quite here yet, and I'd love to see that happen. I do know that, and as I mentioned earlier, Jennifer West at Northern Idaho Advanced Care Hospital said that this is taking place in some of her sister organizations. So anyway, Cheryl, it's great. If you can share your resources, we can share that with this larger group. And I do know that one of the things that people have expressed as we've talked about it is, oh my gosh, my nurses are going to push back on this. So even more so than, oh, my doctors aren't going to go for this. It's been the nurses are not going to go for this. And so I think it's just part of the evolution of quality in healthcare and empowering people and getting folks practicing at the top end of their scope of practice as well. So the discussion today, I want to do a time check. We have about 15 minutes left in our session here. We just want to have some discussion time with everybody who's on the line. We have 37 plus, about 40 people on the line, and that's great. And we will reserve just the last couple of minutes to talk about next steps with you. But what I'd like to do right now is open up the lines. Is that right, Tina? We want to open them up?
Yeah, I think we can cue the operator to let folks know how to pose questions.
Thank you very much.
Hello, Jennifer. Welcome. I'm so glad you could join us. Jennifer was going to be one of our featured speakers, but I spoke for her.
And it sounded wonderful. It was great. They restored the power to our building, and everything's good now. So I just wanted to say that you did a great job presenting how we have our team focus here in the LTAC world way up here in northern Idaho, and I just wanted to see if anybody had any questions for me.
Great. Well, we'll make sure that if any of you have questions about what they're doing at Jennifer's facility, maybe how they're engaging patients and families, which was a kind of unique thing there, please do throw your question or comment forward. You can also use the chat box. I want to just revisit the slide we have in front of us right now, and we've used this each time. We hope that it stimulates discussion. So what excited you about what you heard today, and is there something in here that you could literally do by next Tuesday? So it may not be implementing a nursing protocol, but could it be showing someone one? That's the part. What can you do by next Tuesday? What can you do next week? We heard a good example earlier while you guys are thinking and lining up your questions of Jenna saying, hey, and by the way, I know we're on pulling out catheters today, but I just wanted to know I tried something from session number 2 around the hooks. And I think Cheryl was mentioning one as well. So we're glad that this has been a really good resource for you, and we're hoping that you get to feel and hear the things that people are doing on a daily basis to improve, not just what's in the perfect literature, but what real-life infection preventionists and their awesome nursing staff are doing to improve the care around catheters. And just as a reminder, I'm thinking about all the great things that were mentioned today. I just was jotting it down, even though I kind of knew it ahead of time. The trigger stickers, so stickers and paper charts. Thank you for that. I was so excited to hear about the whiteboards. I hadn't even thought of the whiteboards in terms of, I was thinking in my mind just sort of takes off, and I go, wow, we have Jennifer at her long-term acute care facility engaging patients and families in the care conferences. But then I think, wow, the whiteboards, those are powerful ways of engaging the patient and family as well, and the nursing staff right at the bedside. If that whiteboard is right in the room and they're saying, yes, your expected discharge date is blah, blah, blah. How about your expected date of removing that catheter is fill in the blank. A great way to use your whiteboard, so not just doing a count of the days, but getting that patient or that family ready for your catheter will come out on this date unless. So exciting way to do that. The nurse-driven protocol, Cheryl will be sharing that, and we'll throw in a couple of other examples that we've pulled off the APIC listserv around nurse-driven protocols. And then the rounding, the variety of types of rounding that folks are doing. We have some great folks who talk today, and I want to make sure if anybody has questions or comments specifically for those people, that you go ahead and put them out there right now. And if you can't think of it right now and you want to forward a question later, you can. Operator, do we have any questions?
Our next question is from Meryl Skygy with Skagit Valley Hospital. Go ahead, Mary.
Hi, this is Meryl. I had a question. I can't remember which of the hospitals used the reminders on the Meditech system, and I'm interested in what that reminder looks like and how that was set up and what kind of success you've had with that.
Awesome. That was on the Meditech reminder. That is Jenna. And Jenna, if you have your line muted, go ahead and unmute it. This is Jennifer, and Jenna did send me sort of a screenshot of what that pop-up reminder looks like, so I could always throw that into the information that we follow up and send out to you all. But Jenna, do you want to speak to it?
Well, as far as how we got it implemented, our IT people did that for us, and it's been good. It's worked well. So I can check with them and find out how. Do you guys have Meditech?
Yes.
Okay. I can check with them. I can send you the screenshot and find out how to get that implemented for you.
Very good. That'd be awesome. Thank you.
And what was your name again? Just so
Meryl Shea.
Okay, great.
From Skagit Valley Hospital.
Okay. And for all those people who have processes at their facilities who didn't get to talk today, but you're like, oh, well, we're awesome at this because we have this thing that we do, or we have a sticker that we use. I know I was talking with St. Luke's Health System in Magic Valley, and they were one of the speakers on our very first call, so I didn't throw them into this mix today, but they also use a sticker. A lot of hospitals do have a sticker, and they feel like it works really well. Also, Complex Care, which is a long-term acute care facility here in the Boise Valley, they too use a sticker. They're not super excited about it, but they feel like it's contributed as part of their overall plan, but they're diving into more deeper interventions this year as they focus more on CAUTI. So we can send along copies of people's stickers too, because sometimes there's one sticker that's better than another that's in terms of triggering.
This is Tina, and I just have a comment, which is I know that nurse-driven protocols have been touted quite a bit, but I had sort of an aha moment, which might be a dumb moment for some of the rest of you. I might be a little slow to the game, but it really struck me that it's sort of a 1-2 punch. You really need to have the daily assessment in addition to being empowered to pull the Foley if it's not indicated. Having the nurse-driven protocol in and of itself is not going to be helpful if that daily assessment of needs isn't happening. So that daily assessment piece is really sticking with me today in terms of our conversation, followed by that ability to pull.
You know, you're right, Tina. I'm glad you mentioned that because I don't think that is because we think of, we've kind of touted the nursing protocol as I wouldn't want people to think that that's the silver bullet because it's not. It's just a powerful tool for enabling something to happen immediately at the bedside. That's true. Without the grounding, or without the assessing need daily, whether you're doing that through multidisciplinary rounds or nursing rounds or shift rounds, and or with the patient's family, that nursing protocol is completely ineffective. Yeah, it does not become a reliable process by itself at all. So great comment. Let's go ahead and move on to those last couple of slides because Tina and I wanted everybody to know that just because we're coming to the end of a 4-part CAUTI series doesn't mean that our work and attention towards this is over. We wanted this to kick off our year, with these pillars, rooting everybody in the pillars and the practices that are occurring, the best practices that are occurring across our 2 states. All of these webinars have been recorded and they are archived. We'll add this 4th one to the archive at apicintermountain.com. Thank you to Intermountain APIC for allowing us to store those there. As we move on to the next slide, the work that we're doing is a whole lot more than just webinars. Now, I know we've invited a lot more people than just some target hospitals. We've invited a lot more hospitals to participate in this learning series because we want everybody to be able to learn this all-come-all-learn concept in these webinars. We are working with some hospitals, though, on just reducing rates in general, where we're doing plan, do, study, X cycles to actually drive down CAUTI rates and or to reduce the utilization rate of catheters. So for those folks that we're working with and for any of those others who may be interested in trying to drive down rates at their facility, we will be going into May and June trying to do a plan, do, study, act cycle on the ICU of our hospitals. And so those plan, do, study, act cycles can be as small as they need to be, trying one thing on one unit or with one physician or with a certain batch of nurses or whatever. We can scale that to size so that it's really doable in a short period of time. And so we'll be providing assistance in doing that. And when we do that, we're going to document it sort of like on a one-pager. What's the pillar we're using? What are we trying? What is expected? What really happened? And what we're going to do about it next. We are going to have teleconferences after we have everybody try something. We're going to have teleconferences where everybody comes back and says, well, this is what I tried, and it worked or it didn't work, and what I'm going to do about it now. So we've set those up for June and July. And then come this October, we're going to start focusing in on, okay, now that CAUTI events are becoming rare, what do you do about it when they occur? Let's talk about implementing root cause analysis in the rare CAUTI events that you're having so that you can make sure that your processes are fail-safe, that there isn't, fractured parts of your system that's still allowing harm to occur. And so we'll be focused on doing that this fall, especially after everybody gets their first batch of data that's required by CMS for the inpatient quality reporting. All of that data will be into NHSN. We can take a look at it as a whole and say, this is the frequency. Let's talk about what happens when you have one now. And then in 2013, we're going to go venture together into how to maximize our use and the value of NHSN, whether it's for CAUTI or some other HAIs, looking at other HAIs, but definitely taking advantage of NHSN. What we put in, can it come out? Can it be of use to us? So anyway, we're going to move to the last slide as we've got about 5 minutes left, and I've been so excited about talking about all this stuff. I want to make sure I leave space for Tina in these last 5 minutes, and for anybody who wants to have any last comments, throw them on the chat or let us know. It's been great to work with all of you in putting together this pillar series, and it's been a great resource to large and small hospitals alike. Tina?
Yes, thanks so much, Jennifer. I just wanted to point out a couple things. The teleconferences for June and July, we have yet to release what date and time those will be at, so we'll be in touch about that. also very much wanted to thank everybody who's joined us for this 4-part series. It's really our goal, Jennifer and my goal, to do group action as well as individual one-on-one action, and this webinar series is definitely an example of doing group learning, and our hope, as always, is that all teach, all learn type of environment. And so we're excited for where we've been and excited about where we're going. And my final plug would really be on the PDSAs, on those Plan, Do, Study, Act cycles, to really think about, well, which category might I try something in? Might we get where we're trying to most focus? I might make a pitch for the removal indication pillars, that you might in fact be able to tackle those together. If you don't have a daily assessment process yet, I would highly encourage you to think about that as a place to look for PDSA. That allows you to not only do that daily check and prompt removal, perhaps, but by virtue of doing the daily check, you're incorporating indications into everyday conversation. So that would be my little plug. I guess I would like to open it up now, as Jennifer said, if there's any last comments or questions from the group.
Again, ladies and gentlemen, if you have any comments or questions, please press the number 1 key on your phone. Again, if you have any comments or questions, please press the number 1 key on your phone. Our next question is from Teresa Coiner. Go ahead, Teresa.
Hello. Hi, Teresa. Hi, Jennifer. What a great topic, and thank you. I'm pretty new still to infection control, so I've been learning quite a bit, but I liked your ideas on, the root causes and investigations, and I thought it might be a good idea to somewhere include the tools that maybe facilities use that when they do investigate. I know it's been helpful for me, from my colleagues across Trinity, that they share different, just a little checklist or investigation sheet that everybody does things a little bit different. That's been really helpful, so that's just a comment.
Thanks, Teresa. That's a great idea. As Tina and I start putting together what's going to go into that webinar, you can bet I'm going to be knocking on your door. Teresa is an infection preventionist and risk management nurse at St. Alphonsus in Nampa, Idaho, and comes from a big background in risk management. I appreciate your comments and expertise on that, Teresa.
Thank you.
And just know when you log out of the system, you're going to be offered a Survey Monkey. Please, if you're happy with the series, if you think there need to be improvements, go ahead and put it right into that Survey Monkey. We can take it. We want to hear what you want next. So, thank you. And any other comments, operator? All right.
There are no further questions.
Okay, well, we're going to let everybody get back to your day. We'll give back 1 or 2 minutes of your hour. I bet you can use it. Thank you. Thank you to everyone. Thank you, Tina.
Thank you so much, everyone.